We're going to go ahead and get started. To those of you viewing us on the internet, what you are seeing this morning are first-year students who are presenting grand rounds. Their presentation is evaluated on their case presentation, their ability to come through the differential diagnosis, explain it, basic sciences, latest research, and their presentation. And also, for those of you viewing on the internet, the important thing to understand too is the majority of this is all self-taught from a case they received about 2 weeks ago. So with that, let's go ahead and begin with our first group.
Good afternoon and welcome to our Grand Rounds presentation on Case 27, a 10-month-old boy with microcephaly and episodic cyanosis. Here are the following members of Group 14 who worked on this presentation. I'm student Dr. Sean Lacey, and I'll be presenting the patient history and presentation. Prenatal ultrasonography of a G4-P2 36-year-old mother revealed mild hydronephrosis. Due to maternal hypertension, labor was induced and our patient was born at 39 weeks gestation. The rest of the delivery was uncomplicated. At birth, APGAR scores were 8 and 9 at 1 and 5 minutes respectively. A physical exam at birth showed no dysmorphic features, but microcephaly was noted. Our patient's weight was in the 13th percentile, length in the 60th percentile, and head circumference below the 1st percentile. A newborn screening panel was normal. On the 18th day of life, radiographs of the head showed no abnormalities besides a small cavarium. The patient tested negative for cytomegalovirus and had positive IgG, but negative IgM titers for toxoplasma and rubella. On the 3rd week of life, our patient's parents reported that he rolled his eyes when upset and had labored breathing after feedings. A physical exam revealed palpable coronal ridges. An array comparative genomic hybridization test showed a 16p 11.2 duplication that was originally deemed to be benign. At 6.5 weeks, an MRI was performed. The results showed a small brain, delayed myelination, and partial agenesis of the corpus callosum. At 5 months, our patient's parents reported that he was unable to roll over, developed constipation, and had poor visual tracking. A neurological exam showed that there was decreased visual fixation and failure to track. There was also decreased truncal control and axial hypotonia. The pupils were equal, round, and reactive to light. A neuro-ophthalmologic exam did not reveal optic nerve hypoplasia, indicating a diagnosis of cortical blindness. The head circumference for age chart for our patient is shown on the right. The head circumference for our patient is indicated by the red crosses. Our patient's head circumference was below the 1st percentile. It is also important to note that his head did not grow from 9 months to 11 months of age. At 10 months of age, the onset of symptoms began that consisted of episodes of head bobbing and perioral cyanosis during feedings. 18 days prior to his presentation to us, our patient was admitted to an outside hospital for episodes of respiratory distress with agitation or repositioning. The episodes consisted of near agonal breathing with costal retractions and without tachypnea. Our patient had an oxygen saturation percent that ranged between 80 and 89. Our patient also presented with head bobbing, grunting, back arching, limb extension, increased muscle tone, cool and mottled arms, perioral cyanosis, and bradycardia. The episodes were resolved with oxygen administration. Once the episodes subsided, they were followed by long naps. A CT of the head was performed on this day that revealed hypodensities in the frontal and parietal white matter, mild prominence of the ventricles, and extraaxial spaces containing cerebrospinal fluid. An evaluation for gastroesophageal reflux showed reflux below the levels of the clavicles. A pH probe evaluation revealed that there was no evidence of reflux during the episodes of cyanosis. An EEG showed slowing of the background rhythm without evidence of seizure during the episodes. The patient was administered famotidine for presumptive GERD and lactulose for constipation. The patient was discharged from the outside hospital 12 days prior to his presentation to us. 2 days later, he was readmitted back to the hospital for episodes of respiratory distress and cyanosis. The chest X-ray revealed mild bronchial wall thickening and low lung volumes. Tests for respiratory viruses were once again negative. Evaluation of the respiratory and upper GI tract revealed that our patient had small diaphragmatic excursions and mild esophagitis. On the 10th hospital day at the outside hospital, our patient was transferred to Massachusetts General Hospital for further evaluation. The medications on transfer included lansoprazole, another medication for GERD, and lactulose. Upon admission to Massachusetts General Hospital, our patient's parents reported that his immunizations were up to date and that he had no known allergies. The mother of our patient had 1 successful previous pregnancy and 2 spontaneous miscarriages. The father of our patient and his older sibling were reportedly healthy. The maternal and paternal head circumferences were normal. The only significant familial finding was that our patient's maternal grandmother had a bifid uvula. The vitals upon admission were compared to the vitals during the episodes of respiratory distress and cyanosis. There was a drop in blood pressure during the episodes. The episodes also required 3 times the oxygen to reach an oxygen saturation percent above 97. Due to the episodes of respiratory distress and cyanosis, a venous blood gas was ordered. This revealed that our patient was in respiratory acidosis. He was then started on BiPAP and transferred to the PICU. A neurological exam was performed on the day of admission that revealed no tracking visual stimuli, but the eyes closed in response to bright lights and threats. The pupils contracted from 4 millimeters to 2 millimeters bilaterally, and a red reflex was seen. The face was symmetrical without facial dysplasia. There were spontaneous, symmetric, anti-gravity limb movements. The patellar reflexes were brisk, and there was sustained clonus at the left ankle and 5 beats of clonus at the right ankle. Our patient was unable to sit up without support and lean toward the left. He was also administered lansoprazole, lorazepam, an anti-anxiety medication, and glycerin suppositories for constipation. On the 2nd hospital day, apnea and cyanosis occurred intermittently that were similar to the previously reported episodes. An otolaryngologic exam revealed incomplete vocal cord adduction. A bronchoscopy revealed mild main stem and lower lobe bronchiomalacia on the left side. A BUN was normal. A central venous catheter was placed in the right saphenous vein. Gabapentin, an anti-seizure medication, was also administered on this day. On the 3rd hospital day, an MRI was performed. The sagittal view of the MRI revealed an undersized corpus callosum, a hypoplastic pons, and a hypoplastic medulla. The transverse cut of the MRI revealed a hyperintense signal abnormality, most consistent with a delay in myelination. When our patient's MRI is compared to a normal brain MRI, you can see the undersized corpus callosum here, a hypoplastic pons here, and a hypoplastic medulla here. The hyperintense signal abnormalities are indicated by the asterisks in our patients. You can see them here and here. On the 9th hospital day, our patient exhibited increased work of breathing, bradycardia, and swelling at the site of the central catheter. The catheter was removed, and our patient was started on broad-spectrum antibiotics. Ultrasonography of the right common femoral vein revealed that there was a thrombus and that it was treated with low molecular weight heparin. Ultrasonography of the right... Due to our patient's trouble breathing, he was intubated and mechanical ventilation was started. Because of the concern for an underlying myelination disorder, our patient underwent another MRI on the 16th hospital day. This revealed the development of thrombi in the sagittal and straight sinuses. The vein of Galen appears to be engorged as well. The thrombi are seen as hyperintense signals. The blue arrow in the superior sagittal sinus, seen here, and the white arrow in the straight sinus, here, show the locations of the thrombi. The vein of Galen is indicated by the green arrow, seen here. A repeat MRI was performed 10 days later that revealed that the thrombus had evolved in the vein of Galen, which is seen here. After finding the cerebral sinus venosus thrombosis, a complete workup for thrombophilia was completed. This included labs for antithrombin 3, protein C, activated protein C, and protein S. These labs are within normal limits. Due to a suspected metabolic disorder, homocysteine, folic acid, and vitamin B12 labs were ordered. The homocysteine levels in our patient were elevated over 10 times the normal upper limit. Folic acid levels were also elevated in our patient. As a result of the elevated lab values, betaine, folinic acid, riboflavin, hydroxycobalamin, pyridoxine, and carnitine were administered. A CBC was ordered on the day of admission and on the 20th hospital day. There was a low percentage of lymphocytes in each CBC. There was an elevated platelet count on admission and a low creatinine level on the 20th hospital day. As part of the metabolic workup, blood amino acid analysis were ordered on the day of admission and on the 20th hospital day. This revealed low levels of methionine and cysteine in both sets of labs. On the 20th hospital day, a lumbar puncture was performed. This revealed clear, colorless cerebrospinal fluid with no significant positive findings. I would now like to introduce student Dr. Christina Dami-Lee, who will discuss the differential diagnoses.
Thank you, student Dr. Sean Lacey. I'm student Dr. Christina Dami-Lee, and I will be discussing differential diagnoses of our patient today. Thank you for joining us. Our patient's initial diagnosis was prenatal microcephaly. And in looking for causes for microcephaly, we divided the causes into two categories, non-genetic and genetic. First, for non-genetic causes for microcephaly, we looked into infectious diseases. For torch infections, as previously mentioned by my colleague, our patient tested negative for rubella, toxoplasmosis, and cytomegalovirus. Therefore, we were able to rule this out as a cause for microcephaly. Then for all other infectious causes for microcephaly, our patient had normal white blood cell count as indicated here, as well as having negative lumbar puncture. Therefore, we were able to rule those causes out. Then we looked into in utero exposure to teratogens, for example, alcohol, medications, and recreational drugs. Here on the slide, we have an image of a baby with fetal alcohol syndrome. Babies with fetal alcohol syndrome have facial features unique to the syndrome. For example, short palpebral fissures and smooth philtrum. Our patient did not exhibit any of these facial features, only microcephaly. Therefore, this was ruled out as a cause. Then moving on, we looked into hypoxic ischemic injury. Hypoxic ischemic injury was considered due to our patient's mother's presentation of hypertension during pregnancy. Patients with hypoxic ischemic injury present with problems within the first 24 hours of life. For example, those would be progressive microcephaly as well as abnormal neonatal reflexes. Our patient had normal neonatal reflexes as well as only having prenatal microcephaly, not progressive microcephaly. Therefore, this was ruled out as a differential diagnosis. Then for severe malnutrition, this was considered due to our patient's presentation at birth of below normal weight and below normal head circumference. However, signs of starvation would first manifest in the body, then to the head. Our patient's body continued to grow, whereas the head stopped growing by the 9th month. Therefore, this was ruled out. We were able to rule out all the non-genetic causes for microcephaly, and we further investigated genetic causes for microcephaly. First, we looked into abnormal brain patterns. For example, holoprosencephaly. Here on the slide, we have A and B MRIs obtained from a patient with holoprosencephaly, and C here is from our patient on the 18th day of life, and D here is from a normal individual. Holoprosencephaly is a condition where patients' forebrain fail to divide into two hemispheres. And it's evident on these MRIs that there is no division into two hemispheres. And when you look at our patient's MRI, there is a clear evidence of division into two hemispheres. Therefore, this was ruled out as a cause. And abnormal cortical gyral patterns, for example, these conditions would be lysencephaly and microlysencephaly. Here, if you compare C and D, so from our patient and then from a normal individual, you can see similar cortical patterns. Therefore, this was ruled out as a possible cause for microcephaly. Then we further investigated some abnormal hindbrain structures. For example, specifically looking into pontocerebellar hypoplasia. This was an important differential diagnosis for us due to our patient's presentation of small pons and partial agenesis of corpus callosum. Patients with pontocerebellar hypoplasia present with small pons and small cerebellum. Our patient, although had small pons, did not have small cerebellum, had a normal cerebellum. Therefore, this was ruled out as a cause. Then we also looked into syndromes. For syndromes, we looked at genotypic and phenotypic presentation. First, we looked into Cornelia-de-Lange syndrome. Here on the slide, we have a patient suffering from Cornelia-de-Lange syndrome. Cornelia-de-Lange syndrome have very unique phenotypes associated with it. For example, synophorus and limb anomalies. Our patient did not have any of these presentations. Therefore, we were able to rule it out phenotypically. In addition, our patient's genomic testing revealed no mutations on chromosome 5, which is associated with Cornelia-de-Lange syndrome. And for Seckle syndrome also has a phenotype that's associated with it. It's described as bird-like face with a beak-like nose, as you can see here. Our patient did not have these facial features, only microcephaly. In addition, our patient's genomic testing revealed no mutations on chromosome 3, which is associated with Seckle syndrome. Therefore, we were able to rule this out. We then looked into Rett syndrome. Rett syndrome is associated with mutations on X chromosome. It is also almost exclusively seen in girls. Our patient did not have any mutations on X chromosome. Therefore, this was ruled out. And for Angelman syndrome is associated with mutations on chromosome 15. And our patient's genomic testing revealed no mutations on chromosome 15. Therefore, this was ruled out. We further investigated chromosomal aberrations. Our patient's genomic testing did reveal 16p11.2 duplication, which the author of our paper deemed benign. Then we also looked into craniosynostosis. Craniosynostosis, we were able to rule this out due to our patient's normal calvarium scan of no evidence of premature fusing of the skull. Therefore, this was ruled out. We were able to rule out majority of the genetic causes for microcephaly. We then looked into inborn errors of metabolism as a possible cause. For inborn errors of metabolism with microcephaly, we looked into 4 specific disorders. First, we looked into maternal PKU. For maternal PKU, this was easy for us to rule out due to no evidence of elevated phenylalanine levels in the mother during pregnancy. For Amish-type microcephaly, it's related to mutations on chromosome 17. Our patient's genomic testing did not reveal any mutations on chromosome 17. Therefore, this was ruled out. And for 3-phosphoglycerate dehydrogenase deficiency, although our patient's presentations matched many of those with this deficiency does not have an increased risk for thrombosis associated with it. Our patient had developed thrombi in very unusual places, for example, superior sagittal and straight sinuses. Therefore, this was ruled out. And we were left with severe 510 methylene tetrahydrofolate reductase deficiency, which now I will refer to as severe 510 MTHFR deficiency. Severe 510 MTHFR deficiency has an increased risk of thrombosis associated with it. Patients with severe 510 MTHFR deficiency present with hyperhomocystinemia, thrombosis, apnea, hypomyelination, and although unusual, can present with microcephaly, which was our patient's presentation. Our patient's presentations matched all these criteria. Therefore, we were able to suspect our differential diagnosis to be severe 510 MTHFR deficiency. Now, student Dr. Lane Lagatuda will discuss the next portion of our presentation. Thank you.
Thank you, student Dr. Lee. I am student Dr. Lane Lagatuda, and I will be discussing the epidemiology, treatments, and additional considerations regarding our case. To confirm our diagnosis of severe 510 MTHFR deficiency, gene sequencing was performed. It was found that our patient is a compound heterozygote with 2 novel mutations causing the severe 510 MTHFR deficiency. It was also found that the mother had high levels of homocysteine. Her levels were recorded to be 28 micromoles, with normal being only 10 micromoles. It is likely that the in utero exposure to high homocysteine levels caused the microcephaly seen in our patient. Single nucleotide polymorphisms, or SNPs as I will call them from now on, are the most common type of genetic variation. They occur when a single nucleotide replaces the normal nucleotide in a DNA sequence. They usually result in a benign mutation, however, at certain locations can cause disease. Although severe 510 MTHFR deficiency is quite rare, having only around 100 cases documented thus far, there are other forms of MTHFR deficiency that are quite common. 2 examples of this are the C677T SNP and the A1298C SNP. The C677T SNP mutation is important clinically because of how common it is. It has a carrier rate in Wisconsin for heterozygotes at 24%, and in Italy it has a homozygous carrier rate of 25% and a heterozygous carrier rate of 50.5%. The C677T SNP is the classic 510 MTHFR deficiency SNP. Our patient was found to be a heterozygote for this mutation, meaning that one of the parents was in fact a carrier for this. We can infer that the mother was in fact the carrier for this mutation because of her presentation of hypertension, homocystinemia, and 2 spontaneous miscarriages. It is also worth noting that the patient's maternal grandmother had a bifid uvula, which can also be linked to this SNP. The A1298C SNP is also quite common, and our patient was found to be a heterozygote for this as well, meaning that one of the parents was a carrier for this SNP as well. This mutation presents quite similarly to the C677T mutation, with the additional presentation of ADHD and decreased nitric oxide production. Now I would like to address the 16p11.2 gene duplication. Although originally thought to be benign in our patient, after further research, our team decided that it could have contributed to the patient's phenotype. We believe this because this gene duplication is associated with small head size or behavioral problems, as well as malformations of the kidney and urinary tract. Now I would like to discuss the prognosis of MTHFR deficiency and microcephaly. MTHFR deficiency is associated with the ability to obtain normal height and weight with severe mental retardation, psychotic behavior, visual impairments, and the ability to obtain classic metabolic markers with the proper medication. However, since there are only 100 cases documented thus far, it is hard to predict the exact prognosis. As for microcephaly, this varies from case to case, but is often associated with a reduced life expectancy and little chance of obtaining normal brain function. Since our patient presented with both severe 510 MTHFR deficiency and microcephaly, it makes it even more challenging to determine the exact prognosis of our patient. Here you can see 510 MTHFR. This is responsible for converting 510 methylene tetrahydrofolate to 5-methyl tetrahydrofolate. This is essential for the conversion of homocysteine to methionine. So in this deficiency, you get a buildup of homocysteine and a decrease in the methionine levels in the body. The overall goal of our treatment plan was to reduce homocysteine levels, increase methionine levels, replenish the folate pool, and provide the necessary cofactors for this pathway. It is essential to reduce the homocysteine levels in the body to decrease the risk of thromboembolism. It is also important to increase the methionine levels to ensure that the central nervous system has the appropriate amount available to it. It is worth noting that this deficiency overall affects the methylation of DNA. 5-MTHF and folinic acid were both given to replenish the folates. Betaine was given to help remethylate homocysteine to methionine in the liver and the kidney. Riboflavin was given because it is a cofactor for 510 MTHFR and helps with the remethylation process. Hydroxycobalamin also helps with the remethylation process, as it is a cofactor for methionine synthase. Pyridoxine HCl is a cofactor for cystathione beta synthase and helps with the breakdown of homocysteine. This table shows how our treatment plan worked to effectively normalize homocysteine and methionine levels. You can see that the homocysteine levels decreased to 70 micromoles, while the methionine levels increased to 22 micromoles. It is also worth noting that our treatment plan worked to stop our patients' respiratory failure episodes. In the future, to address the clotting risks associated with hyperhomocysteine, we would recommend giving our patient 81 milligrams of acetylsalicylic acid or another anticoagulation medication like low molecular weight heparin prophylaxis. We would also recommend giving our patient creatine to help lower homocysteine levels and increase the amount of 5-MTHF given. Now I would like to address a few ethical considerations regarding our case. Although it is difficult to discuss when looking at our patient's prognosis, one might wonder if the resources spent on our patient could have been put to an alternative use. On the one hand, as physicians, we are ethically expected to treat the patient in front of us, and in this case, we did just that, pulling out all of the stops seemingly without any cost restraints or restrictions. On the other hand, when thinking in the context of global healthcare, one might wonder if these resources could have gone further in a different setting on patients with a better prospective prognosis. We would also like to address the catheter-related femoral deep venous thrombosis seen in our patient. It turns out this is a common occurrence in the intensive care setting, with up to 18% of pediatric patients experiencing this side effect. Knowing this, it is important that the physicians had an in-depth discussion with the patient's parents before the procedure was performed, educating them on the possible side effects and risks associated with this procedure. We would also like to note that the thrombus seen in the vein of Galen was a direct effect of the severe 510 MTHFR deficiency. In the future, we would recommend the parents meet with a genetics counselor. The genetics counselor would be able to educate the parents on their child's disease, as well as give them the opportunity to get genetic testing done. It is highly recommended that women over the age of 35 who have had issues conceiving, or women who have had more than 3 spontaneous miscarriages, meet with a genetics counselor. Our patient's mother was 36 and had previously had 2 spontaneous miscarriages, leaving her right at the cusp of this recommendation and therefore not having previously met with a genetics counselor. Given this patient's diagnosis, it is clear they will need extra time, care, and medical attention for the rest of their life. This can be tolling on the family financially and personally, so we would recommend joining a support group. We would also recommend meeting with social services to help better educate themselves on their child's disease, as well as ensure that their child has the necessary resources available to him for the rest of his life. The entire family dynamic will change because of this diagnosis, adding increased challenges and restrictions to their daily routines. This not only affects the patient's parents, but also their other child. As for osteopathic manipulative medicine, we would like to address the edema seen in our patient by applying gentle lymphatic techniques and warm compresses. As I previously mentioned, there are not many examples of this case, so there's not much research out there. However, Didosis et al. Performed a study and found that adherence to a strict Mediterranean diet led to decreased homocysteine levels in SMP homozygotes. Christensen et al. Performed another study exposing mice to excess levels of folic acid and found that pseudo-MTHFR deficiency occurred. This is important because patients suffering from severe 510 MTHFR deficiency are put on folic acid supplements and therefore may be at risk to developing pseudo-MTHFR on top of their original MTHFR deficiency. We would like to thank all of the faculty that helped us with this presentation and share all of our resources with you. Sorry. And thank you for attending. We are now open for questions.
Great job, you guys. We're going to start with questions over here, and then we'll switch over here.
One of the questions we received is, what is BiPAP? BiPAP stands for bi-level positive airway pressure. It is a non-invasive electronic device that delivers low pressure and is used to help give, to give ventilatory support for patients who have an intact respiratory tract. This can be done through a nasal or face mask. Some indications for BiPAP are acute respiratory failure, acute or chronic respiratory insufficiency, and documented sleep apnea.
Another question we got is, what does a newborn screening panel consist of? And newborn screening tests look for developmental, genetic, and metabolic disorders in the newborn baby. They differ from state to state, but in general, there's a hearing test, and then, like I said, metabolic and genetic disorders such as phenylketonuria, galactosemia, cystic fibrosis, and tyrosinemia type 1. Also congenital heart diseases, and if the baby's premature, they'll check for car seat adequacy.
Another question that we received was, what are TORCH infections? TORCH stands for toxoplasmosis, other, rubella, cytomegalovirus, and herpes infections. The other infections include syphilis, varicella zoster, and parvovirus.
All right, we'll switch to this side.
A question we had is, what is xanthochromia and what does it indicate? Xanthochromia is a yellow discoloration of the CSF and indicates in vivo hemorrhages such as subarachnoid and possible traumatic lumbar puncture.
All right, another question that we got was, why wasn't factor V Leiden checked? It should have been, actually. That's a pretty common genetically inherited thrombophilia. Its prevalence is about 5% in Caucasian populations, and it's caused basically by a mutation on chromosome 1. The genetic testing which was done on our patient did rule out any abnormalities on chromosome 1, which is how we were able to rule it out. Basically what happens though is a lot of times it's an SNP mutation where it just keeps factor V on in the clotting cascade, so it turns fibrinogen into fibrin and prothrombin prothrombin into thrombin, and then fibrinogen into fibrin. And then on another question we had here was about Reyes syndrome. So that one is a condition that's common, well, not common, it can happen basically in infants where basically they get swelling in the liver and the brain, and it can be associated with aspirin use. So in that case, for that reason, it would probably be better not to administer. I mean, the chances are pretty small, but even so, because it is linked, it would be better to not go that route for even to reduce the risk of thrombosis. Right now, as far as I know, there are not any specific treatments for the condition. I think that they monitor, I want to say they monitor glucose levels and then just electrolyte balances and try to reduce swelling in the brain.
Okay, that concludes our questions. So now I'm going to introduce our guest, Dr. Nathan Hall. He is actually an alum of KCU in both the colleges of biosciences and medicine, and he is currently a pediatric hematology oncology specialist at CMH.
Well, thank you, and thanks for having me. This is a fantastic case for me because I'm a peds hemonc fellow right now, and this is something we deal with on a daily basis. So very good case. Obviously, when a child is born like this, the case walked you through exactly what you need to do. You're not going to jump straight to thrombosis because they didn't see that on the initial scan. So you guys, you walked us right through the case perfectly. You always think of infections, inborn errors, metabolism. Start checking those boxes off. Obviously, the kid finally presented with the thrombus. And so you explained this better than I've ever learned as a fellow in my training right now. So I appreciate this teaching today. So excellent. It's very rare, very, very rare. But every time we have a newborn child that comes in with a new thrombus, this is one of the tests that we run. And I've never seen a positive test at Children's Mercy, but as you had said, there's very few cases out there. And as you had mentioned there's a lot of other testing that we typically do, protein CNS, get some factor levels as well. Things they didn't necessarily do. But nonetheless, you got the diagnosis eventually. So why this is very rare, the key take-home point to this is the high homocysteine levels. When you see that with a thrombus, you know something genetically is going on. So those were the keys to this case. So very good job, you guys. It was excellent.
All right, thank you, you guys. We'll switch over to group 13.
Good afternoon. I'm student Dr. Anastasia Kozleva, and I will be presenting on our patient's admission and history. This is a case of a 29-year-old male who was admitted with headaches, vomiting, and diplopia. These are the rest of my student fellow doctors who are part of Group 13 and with whom it was a pleasure to collaborate on this case. As I have stated, our patient was admitted for headaches, vomiting, and diplopia. 3 days prior to admission, he also started to develop photophobia, neck stiffness, tremors of the left hand, somnolence, and he was found to be mute on examination. 3 weeks prior to admission, our patient was evaluated at a student health center because he was experiencing headaches, blurred vision, nausea, vomiting, anorexia, and weight loss. Unfortunately, we did not have the results of the neurological examination at this time, but we did have a CT of the brain from the hospital, which showed no abnormalities. Our patient was transferred to our hospital from a separate hospital with an MRI of the brain and cervical spine that showed hyperintensity in the cortex along the left frontoparietal region and leptomeningeal enhancement that was most prominent along the basal cistern, pons, and cerebellum. The following medical history we obtained from the patient's sister. The patient was born in a refugee camp in Southeast Asia and immigrated to the United States at the age of 5. It is possible that at this time he had received a BCG vaccine for tuberculosis. 2 months prior to admission, our patient fell off a snowboard and it was possible that he had hit his head. Our patient has no known allergies. Our patient has traveled to the Middle East and Texas 10 years prior to admission through the military. He was also in Texas when he first started to get his symptoms 3 weeks prior to admission. Our patient is a student. He has no known history of smoking or illicit drug use, and he occasionally consumes alcohol. The medications with which our patient came into our hospital with include unspecified pain medications for headache and suppositories for vomiting. Our patient's family history is, he has no family history of autoimmune diseases or cancer. Although his mother did have a prolonged illness that is unknown to us that required multiple unspecified medications while she was at the refugee camp in Southeast Asia. His sisters are healthy. Upon physical examination, he had normal vital signs and he had nuchal rigidity. Our patient was somnolent but arousable by verbal stimuli. He was nonverbal but could follow simple commands, and if instructed to do so, he could write down his name and current location. His pupils were equal, round, and reactive to light without a relative pupillary defect. He had no visual field defects. He was unable to fully abduct his right eye on right lateral gaze, and he had lower facial weakness on the right side. He was able to lift his limbs against gravity without drift. A complete medical testing was done to figure out a differential. Laboratory testing came back negative or unremarkable for CBC, and he had normal complete metabolic panel. He had negative inflammatory markers, and our patient was negative for HIV antibodies. A chest X-ray was performed, but it was shown to have no abnormalities. An ECG showed a normal sinus rhythm and a nonspecific ST changes. Based on the patient's presentation and our suspicion of meningitis, a lumbar puncture was performed at this time. It showed elevated white blood cells, showed elevated protein, and low glucose. At this time, these results made us think of an infection or inflammatory process in the CSF, but all of the patient's CSF cultures came back negative. Our patient was started on lorazepam, and at this time, he was seen to have improvements in speech. He was also started on an empirical treatment for tuberculosis and was given ethambutol, isoniazid, rifampin, and pyrazinamide, and pyridoxine. Because we were suspicious of meningitis and based on our colleagues' index of suspicion, our patient was selectively started on a variety of broad-spectrum antibiotics, antiviral, and antiparasitic medications. Our patient was also given dexamethasone for any inflammation. An MRI of the patient's brain was performed at our hospital on the day of admission. T1 weighted imaging showed diffuse leptomeningeal enhancement, which was most pronounced in the left frontal regions and basal cisterns. As you can note, right here, this white area right here and right here. There was also a focus of restricted diffusion, as you can note by the red arrow, in the left precentral gyrus, which was consistent with ischemia. The results of magnetic resonance angiography were normal. An electroencephalogram was performed on day 3, which showed intermittent background slowing without epileptiform activity. An ophthalmologic examination was conducted at this time, and our patient was found to have blurred optic discs, bilateral abducens palsies, and decreased visual acuity. If you take a look at this picture here, just going to use this one. You can see that this is a normal eye and this is a normal optic disc, which should have very sharp borders. Our patient's eye, however, looked more like the image right here, which has very hazy borders, showing the blurred optic disc margins. Laboratory testing on day 3 came back negative for tuberculin skin test and negative for the quantiferon gold TB test. He was found to have right-sided serous otitis media at this time, and myringotomy results and a myringotomy was performed. The results of the myringotomy showed a sterile aspirate. Our patient's medications were at this time altered, and he was given metronidazole instead of ivermectin, and he was given ceftazidime instead of ceftriaxone. Because his HSV1 and HSV2 results came back negative, we discontinued acyclovir as we did not suspect that to be the cause of his symptoms. At this time, he was given liposomal amphotericin B, but it was quickly discontinued because the patient started to have a rash. On the day 4, an MRI, we obtained thin section gadolinium enhanced MRI, which showed leptomeningeal enhancement surrounding the optic nerves. The optic nerves themselves, though, had appeared normal. A second lumbar puncture was performed on day 4, which showed an increase, once again, an increase in his white blood cells and an increase in the protein, and he had a decreased glucose count. His cultures of the CSF still came back negative. A laboratory testing was done on day 7 for anti-nuclear antibodies. It was shown that at dilutions of 1 to 40 and 1 to 160, ANA had a speckled pattern. This is, however, inconclusive, and our patient had further testing done. He was screened for lupus, and his antibodies came back negative for double-stranded DNA, SM, and RNP. He was also screened for Sjogren's syndrome, and he had negative antibodies to Rho and LA. He had positive hepatitis B surface antibodies, but he had negative hepatitis B surface antigen, which implied to us that he was probably vaccinated for hepatitis B or had hepatitis B in the past. He was negative for hepatitis C antibodies. A craniectomy was performed on day 7, and biopsies of the right frontal meninges and brain were obtained. Examination of the specimens revealed leptomeningeal fibrosis and reactive gliosis in the cortex. Cultures of the brain tissue were, however, sterile. At this time, an external ventricular drain was placed. Over the next couple weeks, our patient's symptoms were not showing signs of improvement, as he still had the same headache, nausea, and vomiting, and he developed a decreased appetite as well as postural tremors, which are tremors that are developed when you're standing still, and intentional tremors, which one has when the patient had when he tried to move. Our patient also started to develop visual hallucinations at this time and an intermittent low-grade fever. Our patient at this time was given as Trianum and moxifloxacin and trimethoprim sulfaminoxazole. On day 24, the external ventricular drain was removed and a ventricular peritoneal shunt was placed. It was after a few days after the shunt was placed that we saw some symptoms of improving, including his better visual acuity, a flat optic disc, and his symptoms of diplopia and abducens palsy seemed to resolve. It was at this time that we discontinued vancomycin and S-trianem. Another collection of CSF was obtained from the VP shunts, and it showed increased white blood cells and increased protein. And although the glucose was still lower than the reference range, it was starting to show some improvement. It was at this time, because we saw improvement in our patient's status and some of his testing, that we decided to discharge and transition our patient to a rehabilitation facility. He was discharged with these medications, as well as trazodone, omeprazole, and ondansetron. Antitubercular medications were continued. Over his time at the rehabilitation facility, we saw continued improvements in our patient. He was walking and interacting, he had decreased nausea, and he had improved oral intake. It is at this time that I would like to hand the mic over to student Dr. Andrew Crebo, as he will discuss the differential and diagnosis.
Okay, thank you, student Dr. Kozaleva. My name is student Dr. Andrew Crebo, and I will be presenting the differential diagnosis. So based off the disease course and the presentation of symptoms of our patient, namely the nausea, photophobia, and visual disturbances, as well as nuchal rigidity, our colleagues thought that it was very likely that our patient was presenting with chronic meningitis. Now, we can speak of chronic meningitis as opposed to acute meningitis in the following ways. Chronic meningitis usually presents with milder symptoms, as well as over a longer period of time. It's not unusual for it to be 4 or more weeks, as well as neurological deficits accruing over a longer period of time. We can further categorize chronic meningitis into infectious and non-infectious causes. Now, before I go on with that, I would like to draw the audience's attention to a few important lab values that will be important in our discussion of the differential diagnosis. Down the first column is just a reference range of values for a normal adult. The second, third, and fourth columns are our patient's lab values on the first day of admission, on day 5, and on day 24. Now, notice the increased protein levels in the CSF, as long as the decreased glucose CSF levels, as well as the normal blood eosinophil levels, all very important findings. Now, for infectious causes of chronic meningitis, we can categorize these under viral, bacterial, fungal, and parasitic. For chronic meningitis, the leading viral cause is HIV. However, upon admission, our patient was administered an HIV test, which did come back negative, so it was deemed to be an unlikely causative agent. For bacterial causes, Mycobacterium tuberculosis is the leading cause worldwide of bacterial chronic meningitis. Borrelia burgdorferi, the causative agent of Lyme disease. Treponema pallidum, the causative agent of syphilis. And Ehrlichia chaffiensis may also present with chronic meningitis. These all 4 bacterial causes will present with the CSF profile that I noted earlier, namely the increased protein levels and the decreased glucose levels. And at this time, they are all still under consideration. Now, for fungal causes, blastomyces, histoplasma, and Candida, they can present with chronic meningitis. However, they're usually in the immunocompromised patient. And since there was nothing in our patient's history, nor in his clinical presentation to conclude that he was immunocompromised, they were deemed to be unlikely. For parasitic causes, the parasitic worm Taenia solium, which causes cysticercosis and is endemic to Southeast Asia, where our patient was born, can be a cause. However, for cysticercosis, you usually would get visualization of extraparenchymal cysts on MRI, as well as an increased eosinophil count, neither of which our patient presented with, and so it was deemed to be an unlikely causative agent. Excuse me. Moving on to non-infectious causes of chronic meningitis. We can categorize these broadly into vascular, connective tissue, systemic, and neoplastic causes. So for vascular causes, primary central nervous system vasculitis usually presents with very specific MRR findings, which were not visualized in our patient. For Sturge-Strauss syndrome, it is a multi-system disorder presenting with rhinosinusitis, asthma, and an increased or with blood eosinophilia. Granulomatosis with polyangiitis or Wegener's granulomatosis presents with fever, migratory joint pain, hematuria, and usually has previous upper airway involvement. And for Cogan syndrome, the patient usually presents with sensorineural loss in the eyes and ears and typically presents in the younger adult. Now, since our patient's symptomatology did not match up with any of the vascular causes, or our colleagues deemed them to be unlikely. Moving on to connective tissue diseases. Now, speaking of systemic lupus erythematosus, we did have positive ANA at 1 to 40 and 1 to 160 dilutions with a speckled pattern. However, antibodies to double-stranded DNA, RNP, and SN were negative, and you typically see those to be a positive finding. For rheumatoid arthritis, the patient would usually present with decreased mental status, seizures, and a high fever. And now for Sjögren's syndrome, it's a chronic autoimmune inflammatory disorder that usually presents with dry eyes and dry mouth, secondary to lacrimal and salivary gland dysfunction. And usually the patient would be positive for Rho and La antigens, which our patient was not. Again, due to our patient's symptomatology not matching up with any of these connective tissue diseases, they were all ruled to be unlikely. For systemic inflammatory disorders, we can break this down into neurosarcoidosis and chemical irritation. Now, neurosarcoidosis usually presents with non-caseating granulomas that are usually visualized on imaging. And chemical irritation, since there was nothing in our patient's history indicating that he was exposed to any chemical irritants, nor that he was a previous drug user, that was also deemed unlikely. Again, due to the lack of imaging of the granular or non-caseating granulomas on MRI, as well as his past history ruling out chemical irritation, both of these systemic inflammatory problems were ruled unlikely. At this time, we're still considering all neoplastic causes for his chronic meningitis, and I will discuss these later on. Now, based upon the lab results, the high protein in the CSF, the low glucose in the CSF, and a clinical picture that would be most aligned with severe chronic meningitis, our colleagues narrowed it down to the most likely causative agents being of tubercular, fungal, or neoplastic origin. And at this time, I just want to briefly go through the evidence for and against these three agents. So for tubercular meningitis, we have the apparent improvement on his anti-TB drug regimen. We also have a matching CSF profile. We have the subacute onset of symptoms. We have stroke that was visualized early in the disease on the first MRI. And again, the possible exposure to TB. His mother was suffering from a chronic disease in an area that has an endemic proportion of tuberculosis. However, his tuberculin skin test did come back negative, as did his quantiferon gold assay. There was a negative chest x-ray for lesions. The acid fast stain came back negative, as well as the culture for meningeal biopsies and the lumbar punctures coming back negative. Now for neoplastic meningitis, our patient presented with a low-grade fever, and in neoplastic meningitis, the patient typically presents with low or no fever, so that matches up well. There was the subacute onset of symptoms, as well as a matching CSF profile alongside moderate pleocytosis. Pleocytosis being an increased cell count in a body fluid, in this case, CSF for our patient. However, there was no systemic signs of a malignant condition. There was no visualization of a mass on imaging, and malignant cells were not, there were no malignant cells in the CSF, though that is of moderate sensitivity. Now, dealing with the final two fungal causes. For cryptococcal meningitis, they usually present with an increased intracranial pressure and a CSF profile of high protein and low glucose, both of which were presented with in our patient. Also, cryptococcal meningitis can present in the non-immunocompromised host. However, our test for cryptococcal antigen came back negative, and usually with cryptococcal meningitis, the patient would present with a high fever. Now, for coccidioidal meningitis, again, the intracranial pressure and the CSF profile matched up with our patient, and the patient did have a recent travel history to southwestern United States, namely Texas, where coccidioidal infections are endemic. However, again, with coccidioidal meningitis, the patient would usually present with a high fever, and coccidioidal infections usually take place in the immunocompromised host, which we had no reason to believe our patient was. Now, putting together the clinical picture and weighing the likelihood of the different causative agents against our patient's presentation and disease course, our colleagues determined that the most likely causative agent of our patient's chronic meningitis was tuberculous meningitis. Before passing on the conversation, I want to briefly discuss typical TB treatment. So when there is reason to suspect exposure to TB, the standard treatment for idiopathic chronic meningitis is to treat empirically, even in the absence of bacterial confirmation. Idiopathic here meaning that no causative agent has yet been determined. So tuberculosis treatment usually starts with a 2-month intensive therapy of isoniazid, rifampin, pyrazinamide, and fluoroquinol, usually as moxifloxacin or levofloxacin. This is followed on by a 9 to 12-month continuation phase where only isoniazid and rifampin is administered. This slide is just comparing our patient's initial 2-month treatment to the standard 2-month treatment. As you can see, they mirror one another nicely, except for, in our case, ethambutol was administered as opposed to fluoroquinol. However, amoxifloxacin was substituted on day 7. Now, the patient's symptoms did continue to improve on the drug regimen, although it should be noted that it's hard to disentangle just the TB treatment as improving the patient, since there was a VP shunt administered as well as glucocorticoids, both of which could have led to improvement in the patient's symptomatology. Having said that, the patient was discharged to start rehabilitation on day 34. And at this point, I'd like to pass on the conversation to student Dr. Aaron Kredovitz, who will continue the discussion on treatment and bioethical concerns.
Thank you, student Dr. Kribo. As he mentioned, I'm student Dr. Aaron Kredovitz, and I'm going to be discussing the final diagnosis, treatment, and other considerations of our case today. As was previously stated, our patient had major resolution of his neurological symptoms. He was discharged, however, 2.5 weeks later, he experienced furthering symptoms such as headache and worsening tremors. He presented to a neurology clinic, and he was readmitted, at which time imaging was obtained. As you can see in this image, there is a non-contrast CT of our patient's brain, which revealed a 3.6 centimeter mass in the left inferior frontal lobe of our patient. It was noted to have irregular margins. Gadolinium-enhanced T1 weighted images were also obtained of our patient's brain. As a note, T1 weighted images will show CSF as black. So as you can see here, right here, these are some ventricles of the brain, and in them is CSF fluid, so it will show up that black color that you would see. Panel A is an axial image, panel B is a coronal image, C is a sagittal image, all allowing visualization of our patient's mass. As you can tell, there's ring enhancement of the mass with central necrosis, which is indicated by the darkened center. In panel D, there is a gradient echo image, which reveals foci of susceptibility. So if you can see, there are a couple of little black dots in the center of our mass, which is just indicative of necrosis or hemorrhage occurring in that area of the brain. At this time, there were 2 different differential diagnoses being considered, the first of which would be a paradoxical response to the initial anti-tuberculosis treatment our patient was given. Patients with this would present very similar to our patient. They would have focal neurological signs, and you could see MASH lesions on imaging as well. The other consideration is a possible neoplasm, which either could have been of primary or metastatic origin. A craniotomy was performed for our patient. However, when his skull was opened, there was a gelatinous material found covering the brain and exuding from the incision site. The surgeon then decided to have a intraoperative frozen section done and stained. which revealed a malignancy. The surgeon then decided to close the patient without completing mass biopsy or resection. Later, permanent stains of the specimen were obtained. On the very far left here, you can see there's an H&E stain of the specimen revealing a small cell malignant neoplasm. In the center, the biopsy was stained for leukocyte common antigen. However, it was negative, which you can tell because there's a pretty consistent blue throughout, and you'll be able to compare it to this image over here on the right in a second. Again, the negative leukocyte common antigen allowed our colleagues to rule out leukemia as a source of the malignancy. On the very far right, however, there is positive staining for glial fibrillary acidic protein, indicating that the malignant cells are of glial origin. Specifically, they are astrocytes. So our colleagues were able to determine that his findings were most consistent, with primary leptomeningeal gliomatosis. It was given a World Health Organization, or WHO, grade 4 of 4 on this scale. Pretty much when you're comparing all the different types of astrocytic tumors possible, necrosis is a big indicator that you have a grade 4 astrocytoma. If you'll recall back on the MRI, there was evidence of necrosis in the center of our patient's lesion, thus allowing us to diagnose him with that grade 4 of 4 glioblastoma. It should also be noted that it's a very aggressive and rare tumor. We were able to rule out the paradoxical response, as I had mentioned before, and again, the findings were consistent with a primary leptomeningeal gliomatosis. This is an extremely rare condition, and it should be noted that only about 50 autopsy-confirmed cases have been found in the literature. It's generally a disease that's diagnosed at a younger age, and the patients have a fairly poor prognosis and generally only live about 4 months after after a diagnosis is made. To kind of give you a better idea of what primary leptomeningeal gliomatosis looks like, essentially it's diagnosed when there's a diffuse infiltration within the leptomeninges and without evidence of a primary interparenchymal tumor. Primary, again, just meaning that those cells were originally from the brain, and that's where the malignancy started. And also leptomeningeal, just referring to the fact that it involves the arachnoid and pia mater collectively, as well as the infiltrate of the subarachnoid space with those malignant cells. 7 days after the initial MRI that revealed the mass, our patient started to experience, some incontinence and leg weakness, at which time a image of the MRI imaging of the spine was obtained. Again, this is a gadolinium-enhanced T1-weighted MRI with that cerebral spinal fluid, which will show up black. Our patient's spinal cord can be seen here in the sagittal plane. This is the cervical area, the thoracic, and then the lumbar, even getting into the sacral area here. Normally what you would find is a little bit darker area surrounding the spinal cord where the cerebral spinal fluid could be seen. In our patient, there is a little bit of a cloudy haze over it with some kind of not so defined borders, indicating that there was extensive enhancement within the leptomeninges of the spinal cord, also showing that there was widespread involvement of the spinal cord in our patient's case. In seeing that there were relatively limited treatment options for our patient, since it was so extensively involved in his spinal cord, it would have required entire irradiation of the patient's neuroaxis, which at the time the treating physicians just didn't believe our patient would be able to handle. He did have a very poor prognosis, and he was experiencing very poor functional status, and so radiation and chemotherapy were not recommended due to that. Our patient was transferred to palliative care, and unfortunately, he continued to deteriorate until he passed away 5 months following the initial onset of his symptoms and 1 month after the diagnosis. Most diagnoses of this are made post-mortem because it is a very aggressive tumor to be diagnosed with. Our patient's family denied an autopsy, so it should be noted that a final confirmation of this diagnosis was not able to be made. In general, the standard of care for glioblastoma is kind of, it's difficult to say. There are a lot of different ways to treat it in the literature, but generally it consists of surgical resection, adjuvant chemotherapy, and some sort of radiation therapy. Generally, involved field radiation therapy is what's used. A drug known as temozolomide, which I will refer to as TMZ from here on out. It's a common therapeutic agent used in conjunction with radiation therapy. And one study showed that 20% of patients who received the combination therapy lived up to 1 year past their initial diagnosis, and as opposed to patients who received the radiation therapy alone, only 11% of those patients lived 1 year past their diagnoses. We also saw 10% of patients who experienced the combination therapy live 5 years past their diagnosis, which is pretty significant given the general prognosis of glioblastomas. The mechanism of TMZ is that it enters the cell and is spontaneously converted to a molecule known as MTIC. Essentially, it just methylates the DNA. The DNA is unable to repair itself, and then the cells apoptose. 2 areas of emerging research we decided to look into are as follows. The first one being MGMT promoter region that is commonly seen in glioblastoma. It's been shown that TMZ therapy used on patients who have a high methylation rate of this promoter region generally respond to the treatment better, allowing for a decrease in the rapid progression of these tumor cells. Epidermal growth factor receptor is also another receptor that can be targeted in patients with glioblastoma. The amplification of this gene and therefore the overexpression of these receptors is seen in about 50% of glioblastomas, and it's thought that it could be used as a potential immunotherapeutic treatment, which would essentially just stop the progression of the tumor and thus giving patients a longer progression-free survival time. A few ethical and legal considerations to keep in mind for our case. This was a case of misdiagnoses. Our patient was originally thought to be suffering from tubercular meningitis. However, we do not believe any malpractice occurred because keep in mind, malpractice suits generally are based on duty, breach of duty, causation, and damages. In our patient's case, we did not believe that there was any breach of duty on the behalf of the physicians. And in fact, the treating physicians did say that they would not have treated the patient any differently, having known the final diagnosis and prognosis of our patient. However, earlier diagnoses will always lead to better outcomes for patients. It gives their family more time to cope. It allows them to make advanced directives, ensuring that the patient's wishes are followed through until, unfortunately, they do pass away. Osteopathic manipulative treatments are generally contraindicated in most patients, especially those with an aggressive type of cancer, such as our patient. Also, he had a very rapidly deteriorating health state, so it was contraindicated that any osteopathic manipulative treatments would be used on our patient. Patient education is also a very essential part of diagnosing patients with cancer, specifically something as aggressive as a glioblastoma. There are a lot of resources out there for patients to be able to find education, which would explain more to them about what their diagnosis consists of. There's also research out there for patients to get involved with and support groups to help patients through these tough times. Doctors should be sure to address all the patient concerns that come along with a diagnosis such as this, such as what the rapid progression looks like, what symptoms to be expecting, and what end-of-life care will look like, especially palliative care, what that will look like for the patient and their families as the final days do start to come to an end. We would like to acknowledge the following faculty for all of their help with our case presentation. Here are our works cited and more. Okay, and at this time, we're open for questions.
Great job, you guys. They're tough cases today. So we're going to start with questions over here. I know you guys got quite a bit of questions, so we'll go from here.
Our first question was, didn't the patient have a normal chest x-ray? What are the criteria of TB, and how can you distinguish between TB and the final diagnosis of TB meningitis? So TB is a bacterial infection by Mycobacterium tuberculosis. So it can manifest as an infection in the lungs, which is most often. Our patient had signs of meningitis. So you'd want to see a positive skin test and a positive quantiferin gold to establish TB meningitis.
You also want positive cultures for diagnosis. And TB can occur in any organ. It does not have to be the lung. Just the lungs are most common. So again, when you guys are in rounds, if somebody asks you what could it be, you're always safe to say rule out TB. No one can ever say you're wrong.
Okay, another question we have is what are some other criteria used to grade tumors besides necrosis? So besides necrosis, in our case, we had MRI and it showed higher vascularization, so it will be another criteria. So we will see increase in blood vessels around the tumor, and also we'll see irregular or irregular borders of the mass and progressive nature of the mass as well. So another question we have is when may I want to order leukocyte antigen test? And in general, human leukocyte antigen test, also known as HLA typing or tissue typing, identifies antigens or white blood cells, determine tissue compatibility for organ transplantation.
So another question we had was, what are some causes of fever? Some general categories that can cause fevers are infections, other connective tissue diseases such as vasculitis or lupus, malignancies, especially lymphoma and leukemia, as well as adverse drug reactions.
When I was in infectious disease, also when they're going through fever of unknown origin, thrombus, they also kind of look for DVTs as well.
Another question that was asked was why he was given trazodone and MOI. And the indication for this was because the patient was going through so much already, it was to reduce any depression that he might have had while he was discharged in the rehabilitation center.
One question that we had was what cranial nerve is affected with this problem with lateral gaze? It would be cranial nerve 6, abducens, since it innervates the lateral rectus muscle, which abducts the eye. Another question that we had is what is the Gauss-Gau coma scale? And that grades coma severity according to 3 categories of responsiveness: eye-opening, motor, and verbal responses. Also, a normal score is 15, and then abnormal is 3 through 14, or a score from 3 to 14. And I think those are all the ones I have.
Okay, so what are some physical exams tests to determine nuchal rigidity? That'd be Koenig's test and Brzezinski's test. Koenig's test is kind of like a straight leg raise, and if you just have pain there, then that can mean meningeal irritation. Brzezinski's test is when you bring your hips to your chest. If your neck flexes forward, that's another sign of meningitis. Yeah. So a positive PPD skin test would be what would be indicative of what type of immune response. That'd be a type 4 hypersensitivity immune response, hypersensitivity immune response. Sorry about that. I had one more too. What are the geographic distribution in the U.S. of histoplasmosis? Would be mostly in the Mississippi and Ohio River valleys, and coccidiomycosis is mostly in the southwest, so California to Texas.
And then one last one that we also had is what is the side effects of rifampin? And that includes flu-like syndrome, and then also hematologic effects such as thrombocytopenia, leukopenia, and then also anemia, and then also hyperbilirubinemia and hypersensitivity. I also have super infections. Did not find that.
Should keep looking it up while.
Okay.
Okay, great job. We will turn it over to Dr. Hall if he's got it.
Thank you. Another great job, great presentation. These are obviously both the field that I love, both the past 2 cases, so very good job presentation. First things I like to say, even if you're going to be a specialist or not, when you see a kid that presents like this, headache, vomiting, diplopia, first thing you have to think about is a brain tumor. I mean, that's what you walk into that room, that's the chief complaint, that's what you got to be thinking and looking for. Then when you see the nuchal rigidity, you start changing your diagnosis as you see things come up. So infections seem to be the the key player here up front, especially with the outside travel, with the mom's history, things like that. So it was very legitimate to go down that pathway. Then you get negative cultures, you have to start thinking, okay, what else could this have been? We actually had 2 cases that were very, very similar to this at Children's Mercy. One we just presented at our grand rounds. It was Cryptococcus meningitis, very similar presentation to this. Obviously we could treat that, and then the other one was leptomeningeal disease with tumors. And so you always have to think of those 2 as this case progressed, I was surprised I didn't biopsy the first time they were in the hospital and waited till the second time when the big tumor presented. That would have given you a definitive diagnosis to go from there. But excellent job presenting the chemotherapy, things like that, because that's something I do on a daily basis. So good job. Sad disease. A lot of kids die from it. But overall, excellent job. This is up there with the last presentation, an attending level presentation. So I had to look some stuff up myself, and I'm giving a presentation later this next week on very similar things. So I might hit you guys up for some slides there. So very good job.
And Dr. Dubin would like to say.
You have your secretions. Okay, orange-colored secretions, yeah. So people in rifampin might have orange-colored tears. The secretions will turn orange. It's a big one because you place patients on that, and they'll call you up like a couple days later saying, "What's going on here?" Just one quick comment about this case for everybody who heard it. This is a group of physicians who wanted this to be TB so bad that they went ahead and made a presumptive diagnosis of TB, even though they had nothing to support it, honestly, except the fact that when he was like 4 or 5 years old, he was in Southeast Asia and his mother may have been exposed to it. But nothing else was there, but they went ahead and came up with that presumptive diagnosis. And it's really easy to get led down a primrose path of wanting to believe something so bad that you make it the diagnosis only to discover it's something else. That's kind of what happened in this case. Anyway, good job, guys. Very good job.
Thank you for coming.